Good morning. Today my topic in the Neuro is assessment and management of encephalitis. My name is Ishita Valambe. Now, introduction. What is encephalitis? Encephalitis is inflammation of brain parenchyma, often due to viral infection or autoimmune causes, can lead to neurological defects requiring multidisciplinary rehab. Now, etiology of encephalitis. Encephalitis causes viral infections in which that is herpes simplex virus, West Nile virus, and then bacterial and fungal parasitics. It is very less common. Now, it can be also due to autoimmune, which example like receptor encephalitis. Now, clinical features of encephalitis: fever, headache, altered mental status, like person is like having mood swings, seizure, focal neurological defect, and cognitive and behavioral changes occur. Now, these are the clinical features like severe anxiety, restored vision, loss of balance, insomnia, loss of inhibition, memory difficulties, loss of language, seizure, psychosis, hallucination, paranoid thoughts. Now, diagnosis. How we can diagnose the encephalitis? That can be through 5 things like neurological examination, CSF analysis, MRI of the brain, ECG, blood test, and viral PCR. Now, this is the X-ray of the herpes encephalitis, as you can see over here. Medical management, antiviral therapy, you can give immunomodulation for autoimmune causes like anticonvulsants for seizure, and ICU care in severe cases. Now, assessment of encephalitis. In assessment, you can do the assessment like consciousness level with the orientation or GCS scale. Muscle strength we can assess through MMT. Tone we can is affected mainly, so we can do the assessment through modified Ashworth scale. Now, balance and coordination is also affected, that we can measure how much it is affected through Berg scale or Berg balance scale. Function mobility like ADL we can use the scale Arthur index. Respiratory assessment we can do through chest expansion, auscultation, and respiratory rate. Now, which are the body mechanisms that are affected in encephalitis? First is level of consciousness. It may range from confusion to coma. It can be assessed to GCS scale, that is Glasgow scale. Orientation to time, place, and person. Now, the second is cognition function is affected. That can be memory loss, impaired attention, slow thinking, possible language discipline like aphasia. And the tools which are used to assess the cognitive function is MMSC. MOCA means monolateral cognitive assessment. Third, which is affected, is motor function, in which there is muscle weakness, abnormal muscle tonus, that is spasticity or flaccidity is present, impaired reflexes like hypo or hypoflexion. Coordination is like issues like cerebral involvement. It can be used to assess with the MMT, muscle tone assessment with modified Ashworth scale. Now, balance and gait is affected mostly. That can lead to ataxia, unsteady gait, risk of falls, poor postural control. It can be assessed through Berg balance scale and tinnitus scale and gait evolution. Now, the fifth which is affected is speech and communication. That can be slurred speech, dysarthria, aphasia if the dominant hemisphere is affected. Now, we can observe through the conversation and refer to a speech specialist. Now, the sixth which is affected is respiratory function, especially in unconsciousness and bedridden patients which are that may have respiratory dysfunction. It can lead to the risk of chest infection, poor cough, effort, and hypoventilation. It can be assessed to respiratory rate, chest expansion, and auscultation. Now, the seventh which is affected is the sensory function loss in alteration in touch, which can lead can be touch, pain, temperature, and proprioception can lead to poor motor control or injury or risk. Now, eighth which is affected is the function independence. ADLs, which is impaired mobility transfer. ADLs assessment can be done through functional independence measurement scale. And the ninth which is affected is the behavior and emotional status, that is irritability, aggravation, apathy, emotional instability, also mood and behavior during the session. Now, what are the physiotherapy goals? To prevent complications like DVT, contracture, bed sores if the patient is bedridden and is in the ICU due to in the severe cases. Improve respiratory function, as I told earlier that if the patient is bedridden in ICU, they can have respiratory dysfunction. Maintain or improve ROM and strength. Improve functional mobility. Facilitate neuroplasticity and motor learning. Now, what we can do in physiotherapy management? First, in acute state, we can do positioning and passive movements if the patient is in ICU or bedridden. Just physiotherapy if there are respiratory issues. Early mobilization as tolerated by the patient. Stretching and RM exercise. Bed mobility. Now, if in the recovery stage, after the patient is discharged from the ICU, we can do progressive resistive exercise, gait training using parallel bars and walkers, balance and coordination exercises, functional task training like sit to stand transpose, cognitive motor integration tasks like dual tasking. Now, these are the tasks we can give for the exercises we can give for the data management. Now, what are the prognosis? Prognosis varies by etiology and severity. Better outcomes with early rehabilitation. Long-term support may be needed for cognitive and motor impairments. Thank you.